With that,
Okay, so good afternoon, everyone.
Yes, sir.
Welcome all of you on behalf of Vidarbha Orthopedic Society Spotlight Webinar Series. In this, Gujarat Orthopedic Association has also joined us. We are so delighted to have uh, Dr. Paula Barbosa, who has also joined us from Brazil. It gives me an immense pleasure to welcome you, Paulo. I know it's 4 o'clock in the morning up there, and I appreciate your commitment when Sunil told me you are joining us. Thank you very much for coming, and a warm welcome to you. Dr. Sushil Babulkar is joined by would-be Secretary Dr. Nitin Kimmatkar here. We both welcome you all. My good friend Dr. Sudhir Kulkarni from Mirrors, he decided and he agreed upon to share my responsibility of moderating this topic of trochanter, which is close to both of our hearts. And so, thank you, Sunil, and welcome to you. I also welcome two of my teachers, patrons, and people who have molded me. Welcome Dr. Tanna sir and Dr. Sudhir Babulkar sir, my father, to this webinar. I hope to have some good constructive fight within all of us. I welcome my good friend from Pune, Dr. Chetan Pradhan. Welcome Chetan.
Thank you,
And my
Sushil.
good friend Dr. Vasudev Gadigune from Chandrapur. Welcome Gadigune sir. I hope Dr. Naveen Thakkar will join us shortly. This webinar putting together would not have been possible without terrific technical guidance from my good friend Dr. Ashok Sham. So really appreciate Ashok to make this happen. Deeply appreciate that. Over to you now, Sunil. All yours.
hi friends, we are going to discuss about the unstable trochanteric fracture, which is very common for all over the world. And still it was an unsolved mystery like neck femur. And we are going to discuss various methods of treating this difficult fracture for especially in elderly and comminuted fractures. So what we are going to discuss is a 3-part, 4-part, the shattered walls and very unstable fractures like reverse oblique. So various varieties are we're getting it, so that we want to discuss these kind of fracture treatment properly. So what are the learning outcomes today? Our role of CT, which is very controversial again. We are going to study the reduction methods, what implants we are going to use, what the segments and other combo fixations, role of replacement, augmentation, and how to avoid the complications. We are going to discuss these points. So is there any need of CT? What is the role of CT? How many people are ready to do for CT and how many people are not ready to do CT in our panelists? Can you start, Paulo? You are now going, I saw your cases, you have done CT for unstable trochanteric fractures. Unmute, Paulo.
Good morning, all. Thank you very much. It's a great pleasure to be here again, even so distant, but our hearts are connected together to India and to orthopedics. We didn't use it, but right now, on the last year or two, we are getting routine CT on unstable trochanteric fracture to better understand the number of the fragments, the position of the fragments, and to get some tips and tricks for the reduction techniques. For simple fractures, we are not using. And the main reason we started was to measure the lateral wall to see if there's how to do it and if it is a real difference using different methods. That's what we do today.
All right, thank you. Dr. Babulkar, sir. Unmute, please.
Routinely, we are doing CT scans since last 2-3 years, but sometimes the cost might be a factor, and in poor people where we just do the surgery, this may not be possible. But it is advisable to have CT in all these unstable variety of IT fractures.
All right. Gadegone. Unmute, please.
Sir, CT is enhanced. It gives enhanced knowledge about the configuration of the fracture. It should be advised, though it is not amenable to my patient.
Okay.
Majority of the stable patient, they looks on X-ray. After CT scan, they are categorized as unstable fracture. Therefore, this should be included in the category of one of the investigation after X-ray, is CT scan. It is my opinion.
Welcome, Naveen.
Yes,
What is your view about CT scan in unstable trochanteric
we,
fracture?
we are not routinely doing a CT only for the academic purpose or classifying the split in the lateral wall we are doing. But the traction X-ray gives almost every information.
All right. Panna sir?
I also don't do CT as a normal situations. As exactly Navin Shah mentioned, AP and the lateral traction X-ray gives us all the information. And on the table, I have almost everything ready. On the table, PFN, DHS, hook plate, the proximal femur plate, everything is available for that 4-part fracture, including the replacement. So whatever is needed, I can proceed to do it on the table.
Okay. Now, getting the more importance, everywhere part of the world is trochanter. Now, my friend Sushrut has studied very distinctly on this, and he has published also his article. May I know now Sushrut to discuss about the CT, role of CT.
So, Sunil, you know my views, but let me clarify why we need CT. See, the importance of lateral wall, people have still unfortunately not completely understood. It's not only broken lateral wall, but it is also the deficiency of lateral wall. So even if you look at the latest classification which AO has put forward, they have classified and they have told how lateral wall should be measured from base of the greater trochanter and putting a 135 degrees tangent to it, and the thickness of that lateral wall should be an X numerical. Now that X numerical was designed to determine if the value is less than though that numerical, then whatever you do, if the patient starts weight bearing, that deficient lateral wall is going to fail. So 3 centimeters, and that value is 10.5 millimeter. If that thickness of the wall is less than that, then that lateral wall is going to break.
Sushrut,
Now
I
the
just wanted to interrupt here. These
It is
2 points were absolutely valid, and they will be discussed in future dual course by
Yeah.
Paulo and as well as Dr. Gadagan.
Yeah.
I recently
So
talked to on CT scan.
I will come back to that. So to measure that deficient lateral wall, it's not possible in a 2D X-ray. It's not possible on a stress X-ray because you have to imagine a 3D configuration. That wall thickness can be decreased anteriorly, anterolaterally, 30 degrees between anterior and dead lateral. So that cannot be seen by naked eye. It cannot be seen by an X-ray. It can only be seen by CT scan. I understand view of some of the faculty panelists here or who are of esteem great this thing. They are considering finances of the patient. They are considering an additional. But if you order 10 CT, I'm sure you can ask the CT scan guy to make 3 or 4 free of cost. And that's possible. We know how to pull the strings, which we always do for the rest of the patient. So for that poor patient, you can always request that decrease the cost or do it free for that particular patient. That's one. Number two, to determine whether it is unstable or not, you need a CT. So there are innocuous looking fractures on X-ray, but CT scan will tell you whether the lateral wall is deficient or not. It need not be broken all the time. It can be deficient. Whether it is a posterior medial fragment involved or not, whether there is a comminution or not, and last type C which we have designed is a burst kind. When there is an anterior comminution, posterior comminution, and a deficient lateral wall, that becomes the worst variety, wherein whatever you do, if you do it without augmentation and putting that osteomuscular sleeve together, the primary implant will walk away very easily. So to identify that is the importance of CT. That's why we have classified 31.2 to 31.3, all these 5 varieties into type A, B, and C based on the CT. Thank you.
Naveen, you wanted to add something?
Yeah. My question is, what does it practically make difference? Because anyway, even with the size of the lateral wall is bigger, there are papers that doing DHS or something, you may breach that lateral wall. You have to be ready with the augmentation at any time, whatever implant you use.
Correct.
It doesn't make any difference in your preparation. I think so.
All right.
I will make another statement.
Yeah.
Can I, Sunil?
Yeah, sure.
All the comminuted fractures, they need a lateral support.
Yeah.
Whether there is a lateral wall fracture, because all comminuted fracture have a lateral wall deficient, either pre-op or a post-op. Even when you do the PFN and then when you put the screw, it becomes deficient. In DHS also, it becomes deficient. So all the badly comminuted fracture, they need a support on the lateral side. I use it with the hook plate, as I think I have shown it earlier. But otherwise,
we are going forward with your case, same thing with explaining. Here we are only discussing about the CT, whether to do or not.
Yeah,
it's what I am arguing.
Okay.
That CT doesn't add anything much to that.
Okay. All right.
Anyway, you proceed further.
All right. Now this again, you want to continue, Sushruth?
No, this is okay. This is fine. This is type A, B, and C. A is lateral wall, B is posterior wall, C is burst lateral wall. If you give me 5 minutes, sometime in between, I will share 2 cases which will demonstrate the efficacy of CT and why not every comminuted trochanter, if you identify properly, would not need a lateral wall augmentation, would need something else. So what something else needs to be done and not lateral wall, I will demonstrate that.
Right.
Okay.
So CT that we have discussed already. I can show you many cases like this case. You can see the innocuous looking, but if you see the CT scan of the same patient, see the burst out what Sushruta has been advocating. There's a burst. So another patient which will show the big posterior medial fragment. It's really a big posterior medial fragment which needs to be identified, which is not seen on proper X-rays. So what implant we want to use? Whether the role of DHS in unstable fractures, again, that's what I put a question mark. Anybody is using a DHS for? Yes, Chetan?
So what's the message, Sunil? Should we be doing CT scan or should we not be doing it?
So majority of the panelists are with the CT. So we'll go for the CT. There will be controversies, but it will be given to the discrimination of the doctors. But
you advise that whenever you see an unstable variety, it is better to do a CT scan.
That's right. Okay.
It will give you more information.
All right. Yes, definitely. So what implant we'll do in the no role of any unstable fracture DHS? Is there any comment want to make, Dr. Tanna sir? Start with Dr. Tanna.
Yeah, unstable fracture unless you are medializing.
Yeah.
Which I think I have sent you a case there. Probably the ordinary fracture which you are not medializing, there is no role of a DHS. I agree.
Yes. Dr. Babulkar sir?
All these unstable fractures requires augmentation.
No, DHS, whether you will use DHS or not, that's
No.
yes or no.
Intramedullary nail with augmentation.
All right. What about Dr. sir? Dadevane, unmute please.
I don't do DHS for an unstable trochanteric fracture.
You don't do it. Okay. Paulo?
No, we are not doing DHS even with the plate for support or any other different techniques for unstable fracture nowadays.
Okay. So everybody is in favor of nail with or without some augmentation. All right. So we'll go for further.
मैं बाकी रहेगा हाँ?
Whether you want to use fracture table, stable table, or both advantage, disadvantage. Some people were discussing about training with the simple table and table. So Follow, what do you do? You use a traction table or a simple table to do unstable trochanteric fractures?
I do almost all my fractures in a fracture table. I think it's a great help. Helps to understand the fracture and the reduce at the beginning of the case, keeps the reduction when we need, and don't mix it up during the surgery. So I'm really, really a good fan of the fracture table. But as a trauma surgeon, we need to know how to do it in a simple table.
Right.
We have sometimes patients with more than one fracture, with pelvic fracture. So every surgeon needs to know how to do it in the simple radiolucent table.
Any panelist wants to add something? Yes, sir. Pablo, sir.
Yeah, I always use fracture table, but keep ready some joysticks. It might be required without opening the fracture, where you can achieve a perfect reduction. Reduction is important.
All right. Yes, Naveen.
Only when there is a subtrochanteric extension and the proximal fragment is too much of flexion, many times it helps in the lateral position to get the reduction.
All right. What about Chetan? Yeah.
I always do only in lateral position, whether it's stable or unstable, and it immensely helps me in two things. One is the entry point becomes very simple in obese patients, and the second thing is if I have to reconstruct or augment, then going anteriorly and posteriorly becomes more simpler in a lateral position.
Simple lateral table, simple table, not
Yes.
the fracture table lateral.
No. Simple on ordinary table.
Ordinary table. All right. Okay. So I welcome Dr. Gadegone to show his reduction techniques. Right? Okay. Go ahead, Dr. Gadegone.
Yes, this is introducing a new concept. You cannot call it as a new concept because everybody is doing it nowadays. So reduction is a key to this successful surgery. That is the most important thing. And slight valgus is the most important on seeing the AP X-ray. And lateral X-ray, there should be anterior cortical continuity. That is the most important. So that is known as a anteromedial reduction. And when you are doing on a fracture table or on a simple table, it is very difficult to keep the reduction intact for a period of time. Therefore, we have to fix it by temporary fixation after a reduction, that is anteromedial pin is pushed. Suppose if you are not getting a reduction, then you pass a Steinmann pin from the anterolateral part percutaneously at the fracture site, and then you intrafocally manipulate the fracture seeing under the C-arm, bring anterior and medial cortical continuity, and then pass 2-3 mm pins from the lateral side that will not come in the way of your nailing and guide wire placement, and then you can do a adduction that will prevent your varus as well as loss of reduction. So you can do a close reduction by Steinmann pin technique, or you give a small incision at the proposed site of the screw incision, and then you can pass a Homan's retractor over the anteriorly translated neck fragment, depress it, and with the Sands pin or Steinmann pin, you can elevate the distal fragment, bring the fragment together, and then do a temporary fixation. And then after the nailing is over, if you feel that still the fracture remains unstable, then you can take one of the technique of augmentation, maybe plate, maybe circular wire, or maybe additional fix. So stability of the fracture after the implant fixation is primarily depend on the quality of a fracture reduction, and it's not on the implant at all. Whether you do a 2-screw system or a 1-screw system, it does not matter very much. Now this is the X-ray, a 4-part fracture. On table it looks like a fracture is reduced in AP X-ray. A slight valgus is always necessary, but in lateral X-ray, you will find there is a translation and posterior sagging. Translation of anterior fragment and posterior sagging. So other method is a small incision give and pass a Homan's retractor with the clamp or with a Steinman pin, or you can use your Chance pin also. Just lift the distal fragment, bring together the anterior fragment, and pass a anterior-medial pin to stabilize the fracture, and then you do your further procedure. So this is the most important thing you have to do. Next,
Somebody-
anyone want to ask the question?
Mobile is ringing. All right. Anybody wants to add to this?
Yes, can I?
Yeah.
Yes, yes.
Now, all these unstable fracture requires some sort of fixation temporarily.
Yes.
Routinely, I put a K-wire which will not hinder the guide wire or reamer, and maintain that fixed position till you pass the nail. Sometimes when there is a coronal split, it is necessary to put a wire loop, circlage wire loop temporarily, but do not tighten up till you have passed the nail. So some sort of joystick method is necessary, either K-wire or putting a temporary circlage to maintain the reduction before we really pass the guide wire or reamer.
All right.
Can I ask something?
Yeah, sure.
That I think this is what is in the slide right now on the previous slide. It's a major topic, and it is not well addressed in many of the papers and the literature. Is that this anterior pillar is the only landmark we can appreciate. And if you see the blue arrow, I pay a lot of attention on this because this means rotation between the proximal fragment and the distal fragment. Every time I see this big spur anterior, it means my fracture can be aligned on the AP, but it's truly an internal or external rotation. And we can fix this, and the patient is going to end up with appear to be a well-reduced fracture, but has a huge, usually internal or externally rotate. So I pay a lot of attention of this spur, and I play with the C-arm until it disappears. As you can see on the right, on the bottom of the slide here, it's a perfect reduce. So this spur, you can see here, the spur is in contact with the distal fragment on the top of the lower right. You can see that the spur is in line. It's a perfect rotational, reduced, unstable fracture. It's very important. Very good.
So Paulo, question to you: if you see this, do you kind of open that up and reduce it under vision to push it down or derotate it?
Well, as I use the fracture table, I get usually internal rotation to get the alignment of these two on the perfect lateral view, as we can see here. Okay. If needed, I put a joystick and I can play. I like the joysticks. I think it's a great tool for indirect reduction.
Sure.
Unmute, sir. DDT one. Dr. Tanna wants to join.
Hello, can I hear?
Yeah.
I think this is most important. And if in case you don't get it by closed methods, there is no harm in opening up the fracture. Because you can open up the fracture anteriorly, and in the intertrochanteric fracture, by opening the fracture, you are not harming the healing process. But you will have a much better mechanics understood. Because so many times when you try to do it by closed methods, you may not be able to get 100% reduction. If you get 100%, it's perfect. Otherwise, go ahead, open it up, get 100% reduction, and then only proceed.
Absolutely.
Absolutely correct.
Yes.
Sunil,
Yes,
there is one more.
I am going to show that demo case of open reduction.
Yes.
So there are many ways to do this type of reduction. You can use a clamps. You can use a bone hook by giving a small incision, as Dr. Tanna said, that you give a small incision, put a bone hook and just lift the leg. You can also use a Hohmann retractor, or also you can use anteromedial pin. So these are the methods of doing a reduction percutaneous or semi-invasive methods, and that instrument must be ready on the trolley when you take the patient for surgery. That is clamps reduction, cerclage wire, bone hook, Hohmann's retractor, Sans pin, and 3 mm and 4 mm K wires and Steinman pin. These are the must on the table, and majority of the fractures can be reduced by close method, and you must have also a hook. That is a very important hook to reduce the lesser trochanteric part by pulling it, by pushing, by mini invasive method. So as far as possible, try to reduce by close means with various apparatus used for that getting the reduction. And if you are not able to do it, give a small incision, see medial and anterior wall, and reduce it and do a temporary fixation, and then you go for nailing. Because the most important part is the anteromedial part is the only part which has a very intact bone, strong bone, so that we have to assess. You just cannot assess by a posterior wall.
Sir, can I stop you there? Gadigone, sir.
Yes, sir.
How will you assess the integrity of anteromedial wall on a plain X-ray?
The cortical continuity of one trabecule to other fragment should be there. That is the restoration of, as you see the sentence line here on the AP X-ray, the same sentence lines like landmark should be on the anterior side also. And the trabecule, calcar trabecule should travel along the distal part of the femoral fragment, and that is the only indication. Otherwise, small rotation will show you there is a mismatch between the trabecule traversing from calcar to the distal fragment.
Okay.
And Shushruta, even in a lateral view,
Yep.
you will be able to see the whole reduction, which is not right. If you have CT, you don't have a CT. Because as you can see it here in the blue arrow, which is there, in a lateral view, once you see that, you know very well that this is not the one which is going to be acceptable. So you will make all the efforts to reduce that.
Okay.
Chetan, yeah, final word.
Yes, this sag which we commonly see of the distal fragment can easily be avoided if you are doing it in a lateral position. It is much comfortable to do even a mini open or a formal open reduction. I follow what Dr. Tanna sir said because I trained with him, that if I'm not happy with the reduction by close means, I would not hesitate to open it and reduce it nicely before I start my nailing. But it is more simpler to do it in a lateral position. More often than not, this sag automatically corrects in lateral position.
All right. So
Many times you have to use the double clamps, for the one clamp for the proximal, one clamp for the distal fragment when you do a open reduction.
okay.
Clamp assisted.
Suppose if you want to do a DHS in trochanteric fracture, why it fails? Again, I will request Dr. Gadegone to continue and stress it because this is going to be a repetition by Paulo as well. So make it short.
Okay, second slide, sir. Now you can see here, this is the X-ray because I did it at 10 years ago. Therefore, the quality of X-ray is like this. But this is a two-part intertrochanteric fracture, and you can appreciate a very thin wall on the of the distal fragment. Now, this fracture, since it was a stable fracture, it was treated by the DHS only. But that time I used to DHS in all types of fractures. Then I converted it into iron nail in unstable trochanteric. On observation, it appears that the reduction is good, TAD distance is maintained, and placement of the implant, I think it is ideal. So to house, is there any lacunae in this fixation?
Yes, I think you have broken the lateral marks there, and it should have been added up the cerclage wire coming from trochanter all the way down. Then you would not have had a problem here.
Correct. It will break. It will break because you did not assess the thickness of lateral wall on CT. Your plain X-ray will not show it. If you would have done CT, so-called stable fracture, you would have used it.
Prabhu, I'm sorry, I didn't phone because I was busy during this
There are two things. One is the lateral wall is broken conservatively, and the second thing is there is no derotation element in this fixation.
Yes, now the lateral wall is broken, the stable fracture is converted into unstable fracture, and there is nothing to support above the DHS barrel.
So is it a day one failure?
It could be before
before
the paper there is 32% incidence of per operative breaching of the lateral wall by DHS barrel.
Adegone sir, it is not
Yes.
day one. It is before you did DHS failure.
Failure is there. Okay.
Before
So that-
planning also. That's why I am suggesting that this deficiency of lateral wall has to be understood.
Yes,
It is not your mistake. We all did it. 25 to 30%, we all did it.
That was the message we want to give to the all audience, that
Exactly.
the lateral wall, it is thinned out. It is better to think of something different.
Exactly, yeah.
Exactly.
Garigune, if I can add up,
Yes, sir.
even when you do a PFN,
Yes, sir.
when you're doing the screw fixation inside in the PFN, the
Yes.
intact lateral wall can still break also
Yes.
by that screw.
Yes, yes, sir.
But sir, it depends on the size diameter of the screw also.
Agreed. So I think that if in case it is a thin lateral wall, then as exactly mentioned earlier by any few of us, you start making a small drill, bigger drill, bigger drill, bigger drill, and ultimately put in a triple trocar. And then you will be able to save the lateral wall. And then as a precautionary, every time I do a DHS for this, I put in a tension band onto the trochanter.
So can I barge in here?
Hmm.
Sir, it is not the question of how cautiously you execute the surgery. If the wall thickness is less than 20.5 millimeter, it will break when the patient starts weight bearing. So you are trying to take care of that by putting a prophylactic wire. Fine. But if you know that that 20.5 millimeter is less, so the lateral wall is deficient, if you put an intramedullary device, your intramedullary device will take care of that lateral wall, even if it breaks, because it is one chunk of lateral greater trochanter. So your thickness of intramedullary device will take care of that. That's the debate.
Excuse me.
Yes, sir.
Up till now, we have been talking about it, that even when a PFN, the lateral wall is broken, it's not safe. Now you are talking just the other way here.
So the thickness of PFN was not that great. Now the modern nails are proximally much more thicker than the thickness of the PFN. So that thicker proximal nail.
Let me interrupt now. You
No,
are
no,
going
no, no.
ahead, very much ahead. We are going to discuss
Sunil.
what is better. We are discussing here why THS failed. Just restrict your to talk.
Only limited issue we are discussing.
We are going ahead. We have plenty of time to discuss this PFN or how to do it. Yes, Paulo, you want to add?
Sunil,
After 1 minute.
I think this is a great discussion, and I just wanted to know, 15 years ago, this case wouldn't be a bad result because the fracture healed. So nowadays, we know that if the fracture heals like this, excessive shortening, medialization is functionally bad. Because 30 years ago, the DHS was the solution because he was able to collapse and let the fracture heal. So the fracture is going to heal, but in a very bad functional position. That's the major topic here. And I think it fails because it breaks the lateral wall. We're going to have a very nice discussion if as I totally agree with Shushu, that the nail, it's the mechanical support, even with the lateral wall fail. But for me, it fails because the lateral wall is gone, or like in this case, excessive medialization of the whole fragment. This is positive or negative reduction. We can discuss it later on.
Yes, Babulga sir, you wanted to say?
can I see immediate post-op X-ray, which I want to comment?
Previous.
Yeah, this is the one.
Now, realizing on the table that there is a broken lateral wall, here initially before putting a DHS, he should have put an anti-rotation screw and put a TSP
Sir,
Surprise wire.
we are discussing not the solution. We are discussing why DHS failed. That's the reason we are discussing. What we should be doing, we will be discussing later.
They should have avoided failure.
Yeah. Okay. So this is
the thing
Yeah.
that they actually this X-ray was this surgery was done in 2007. So that my understanding that time of lateral wall, as you also, was not very much. Now I am retrospectively thinking and getting the X-ray reviewed because the quality of X-ray you can see with the small X-ray machine that the lateral wall thickness here is only 18.2 mm. So as said that the Sushruth said 20.5 is should be the minimum lateral wall thickness conducive for the DHS fixation, otherwise it will fail. So more than that it should be. Therefore, the lateral wall fracture is much more common in this thing, and this is the most important article from the horse's mouth. If it should be 3 centimeter, this is from the tubercle, this should be 3 centimeter, you measure it to a 35-degree angle, and if you find that the wall is less than 20.5 mm, then it is likely to fail, even A1 and A2 fractures also. And after the fracture of the, because of DSH fixation, A2 fracture will convert into A3 fracture, and there will be a progressive medialization, and that is the cause of failure, and therefore we are discussing this. Next slide, sir. And this is how
Radhegana sir, एक second.
Yes.
Just one interruption. Even on table, it is not physically broken. The moment patient will start weight bearing, this deficient, less thick lateral wall will break, is the point which I am trying to make. So on
Yes,
table, it will still look fantastic that you have done a great job. It will not break on table. It will break once the patient starts weight bearing because it is deficient. The thickness is not sufficient enough.
There are papers of per-operative and post-operative breakage of the lateral wall.
Yes, yes.
Yes. So the lateral wall is the most important predictor of a success of intertrochanteric fracture, and it usually happens during the triple ribbing of the head screw. Lateral support leads to medialization. To get it stabilized, you can see here fracture heals, and there are plenty of examples in your practice as well as in the literature, and this is the main cause of failure of the DHS when lateral wall is thin and precarious. So this was the message Dr. Sunil wants to give, and this is all supported by the literature. 36% failure rate even in a stable type of fracture. So it alone can lead to poor radiological and functional outcome independent of TAD distance. Lateral wall thickness is a reliable predictor of intraoperative lateral wall fracture during DHS fixation. Is this the message, Sunil, you want to give to the all delegates? Sunil.
Unmute, Sunil.
Unmute yourself. Unmute.
You keep
Sunil,
yourself
unmute.
unmuted all the time, Sunil.
Oh no. Okay.
So this was the message you want to give to the all delegates that lateral wall is the most important thing.
Yeah.
So these are all X-rays.
Yeah. So now we are going to the IM nail. Now, the second part is which nail? 1 screw, 2 screw, helical blade, long nail, short nail. All going to discuss about this. As you know, this now it has been proved that this is a 3 types of assessment of the reduction. So if it is in valgus, so if it is a midline, the proximal fragment has gone inside the shaft, that means it is varus. This is neutral, which is exactly one, and what is positive is that proximal fragment is medial to the distal. So that is desirable probably if it is not possible to do it. So now I welcome Paulo to talk about this. You know, Paulo is a professor of orthopedics and AO International Faculty and AO taking expert group. We are happy to receive you here, Paulo, and you go ahead with your talk.
Do you have control for the, or
No, you just say next and Sunil will operate it for you.
I have. You just say next, I will put it out there.
So this is a typical case that you guys do every day. A 90-year-old female had a fall in the middle of the night, didn't want to wake up any of the relatives to go to the toilet. No major comorbidities, just the normal heart disease and the coronary high blood pressure. So this is the case I brought to discuss, one, what you guys like the indication or not for the CT. This is a very old case. It's a 14-year-old case. And I just want to show here, we can identify with the plain X-ray that we have the posterior medial, we have the head, neck, and the spike. That it's a very, very important tip for reduction. We have the lateral wall, or connected with the shaft, and we can also have the greater trochanter, part of the greater trochanter up, as you can see here on the blue. So this is our X-ray evaluation. So can we measure the lateral wall with this X-ray? That should be the definition to measure the thickness of the wall. But where it is on the AP, it's that's the first line, or it's that's the second line, the thickness, it's posterior. So I want you to comment, or if there is any questions about the definition of instability, do we need something else, or no, this is okay, and what to do now?
Yes. Chetan, want to comment on this?
No, I would also like to have a lateral X-ray, a good lateral X-ray, to understand the fracture morphology better. These are the ones where now I would do a CT scan and try to estimate the thickness of the lateral wall, because I'm still not very clear on this as to how to measure that thickness and from where.
So if you have to do it today, are you going for the lateral X-ray at the emergency department, or no, you go directly to the CT and we skip the lateral?
No, I would do an X-ray first. I'd do a AP with traction and a proper lateral X-ray, and then decide about whether to do a CT or not. If the X-ray is showing me all the components of the fracture, I would not send the patient for a CT scan.
Okay, any other different comment?
Follow the what you show, the posterior medial. This posterior medial is very deceptive in X-rays. If I show you, this is rotated, so you don't see the actually exact how much is the posterior medial fragment. That can be extended right from the trochanter to the posterior part. So I just shown a CT, which gives a huge posterior medial fragment.
Yes, we used to say that every time you order a CT, the fracture shows how bad it is. If you don't want to know, don't ask in CT. But as we plan for the worst, when I see the posterior medial fragment, I know it's bigger, it is important, and I can't do anything about it. This is a fragment that I don't go for that. I will rely on my implant to work as the posterior medial fragment. But what Chita said, it's very, very important, just 1 minute, because you need to know what we want. And the CT, it's very good, and we do now on this kind of fracture. But we also have the lateral and the traction view, because it changed completely the way you see the lateral view. So we do all three images to see what kind of information we can have with both of them. Yes.
Sunil.
Yeah.
AP view, traction view, and lateral will give a lot of information. And if CT is possible, it is good. But if it is not possible, you should have traction views.
Okay.
Do you want to say something?
Could you go ahead and push the button? Can you just keep going?
Next, Sudhir.
Next slide. So that is my biggest question about using the AP, the simple X-ray to measure the lateral wall. Could you keep going, Sunil, and I'll talk?
Yeah, yeah.
If you get this, if any externally rotate a little bit, this number will change. Keep going. If you externally rotate a little bit more, you decrease the measure on the AP lateral. And if you, by the way, by chance, you do an internal rotation, then your number is going to be totally improved, but it's a fake number. Can you go ahead? So that's why I don't use plain x-rays to measure the lateral wall. And that's why, that's when we started to use more and more the CT scan. Can you go ahead? Because with the CT, you can get at the exactly point, or you can compare from the top to bottom the real size of the lateral wall. So besides knowing all the other fragments, you can have the whole and the true measure of the lateral wall using the CT scan. I don't know what you think about it.
But Apollo, I want to have one question. Whether you use a digital meter measurements to measure this, or you have to have separate, because it may be a magnification on your CT monitor. So you have a magnification of the views of the CT scan. So how do you actually measure it by a digital measure on the software?
With the CT, you can get it more. You can get it real because the CT is also auto calibration. You can rely much more on the measure of the CT scan than with the X-ray. But to be on the safe side, we use the 10–15% magnification to get the range of what we are measuring. But if you ask me, digital X-ray or CT, I rely on the CT measurements.
All right.
Not the digital X-ray, because of what you said.
Yeah. Anybody wants to ask any questions to Paulo, or go ahead?
Go ahead.
Okay.
So when you talk about fractures, like an trochanteric fracture, this is true, and already said here at the debate, reduction is everything. No matter which implant you use, if you don't have a reduction, you're going to be in trouble. And as we know, we need to be Dr. Google about reduction techniques. We need to know all of them. And this is my menu of reduction techniques. So if you go to the next case, to the next slide. So this was, I forgot to ask you about the implants, but no matter, can you go back? Previous?
Yep.
One more. So this is the patient on the traction table, and this is the lateral view that we had. So my first option of traction didn't reduce the fracture. So now I'm in trouble, and I ask your help how to get this fracture reduced.
Yes.
Chetan, go ahead.
Can I?
I think.
Yes,
Can I?
Chetan.
Sunil? Okay.
Right, Naveen.
Yeah. You may need an open reduction. I'm going to show you the live surgery I demonstrated. The same condition was there. On traction table, it was not buzzing at all. So we decided immediately go for an open reduction.
Patient, what he will do?
Open reduction is required. I should be ready with the open reduction.
All right. Next, Chetan.
No, you can still attempt a close mini open reduction. So you will need one K-wire, what Dr. Gadigone demonstrated, a K-wire in the proximal fragment and one Steinmann pin in the distal fragment to lift it up. So this is the classical sag which you see on a fracture table, and no amount of traction is going to reduce it. So you will need to handle both the fragments, then get a reduction, and then temporarily hold it with a thick K-wire.
Chetan, I wanted to ask, if this is not reduced on fracture table by giving traction, how the man holding your thigh when you are doing a lateral simple position, you must be having a Mr. Universe to pull that thigh.
No, you don't require that much of a traction in lateral position. This is more of a sag. And whenever you see that it is not getting reduced, you do a minimal open, you use any trick that you can you want. But in the lateral position, it is far more simple to reduce it by open means also.
All right.
There is a possibility of soft tissue in between. There is a possibility.
So then you can use a joystick, you can use a homans, you can use a hook, you can use anything and get that reduction and temporarily hold it.
Yes,
Can we go Polo?
I really like because you all experienced surgeons address all the problems. With this sag, we have at the orthopedic table a pusher to reduce it, and I'd like to try everything close it and following Chetan advice. Can you just go one slide? I tried the Homan one at the proximal fragment and the second one on the distal fragment. We could align a little bit better. But do you think this is a well-reduced fracture right now? Yes or no?
No, it is very difficult to maintain during the whole procedure. So you may require to keep with the clamp both the fragment and keep it steady till you fix completely.
Or
Yes.
put guide wire till it.
May I interfere?
Sure.
Why this is not direction is not coming? It's because of not only the traction issue. Traction doesn't reduce the fracture. It's a rotational issue at the fracture side. So you lift the fracture, rotate it properly, and you get the alignment. It's very easy.
Yeah, we try. Can you go one slide more? So it didn't fail. The traction failed. The Homan failed. So we decided another technique. So we put the guide wire on the distal fragment. Remember, it was completely destroyed entry point, so there was no problem to get to the distal fragment. Can you go one slide? And this is the nail. So we inserted the nail and we sealed the gap. Can we push one more?
Use the
And
nail.
using the nail as a lever arm to rotate it and elevate the distal fragment, we use the ball and spike on the proximal fragment, as you can see. So now we have the alignment of the anterior cortex, and we can rotate to see if there's any rotation. Can we one more? And we can manage, because remember, we have one going up and one going down. So we can manage to keep it until we put the blade on. Just one more. And here's the patient already at the 3 month with a very nice collapse. This is a very old case. And this proves that the collapse is controllable, that we had, look at the posterior medial fragment, the very nice callus and very nice consolidation, and even the greater trochanter, everything went up for a very nice healing because of indirect reduction, non-disruption. Can you go one more? One more slide. And this is what, just one back. And this is what we used to say from our menu of reduction techniques. I had to use the manual traction, I used the traction table, I used the spike and the pointer, and I used the IM nail. So I used a lot of different closed methods of reduction and not just one. Yes, I totally agree with you. Open reduction is not a thing, it's not a problem, and can be done anytime you don't have an adequate reduction.
But Paulo, do you recommend now, because old one, because nail is not a reduction tool? That's right from the many years.
And do you feel there is a gap and that has collapsed and it has gone into some varus and may have a limp?
Actually, the collapse was...
If you can go back one X-ray, please. One or two.
Actually, do
you think it has gone into the varus?
No,
and excessive collapse?
No,
Then the previous one?
I have the whole case here. As you can see, it's from 2006 when we started to use the TFN at that time. And it was a completely wrong measure of the blade. And the blade
Doctor,
was...
if I can butt in. Can
the
I?
nail was, yeah.
Now, in order to do this growth reduction, you exposed yourself to too much of radiation. And if we are doing too many operations a day, how much of the radiation you get? I think there is enough reports that lots of orthopedic surgeons get too many radiations. So I feel that if in case you have to do it in a big extended ways to do the growth reduction, it may be safer to do an open reduction and save yourself so much of a radiation.
Yes, I think this is a concern. There are several studies on surgery with a very large volume of procedures, and we use all the protection that are available. I use the goggle, I use the thyroid protection, my gun, it's a real new one, and I always change it. And the only thing I don't use is the glove. We don't
Sir.
have it here in Brazil. We don't
Sir.
have
Wait,
protection.
wait. Let him complete.
Oh, yeah.
But I totally agree with you that radiation is a problem, but everything is good for the patient is bad for the doctor, anything. And I think that today I have a lot more, not only experience, but instruments. This fracture I reduced with the collinear clamp today in just one shot, 1 or 2 shots, and the collinear clamp solves the problem, and I can use the same implant that I use.
Yeah. Do you think that there is no hold of the proximal nail has no hold in the proximal fragment, because it is through the fracture side you maneuvered that for reduction by nail?
The reduction using the nail was a lever arm. We have been told that the nail is not a reduction.
Nail was not through the proximal fragment. There was nothing from the proximal fragment and nail. Only it was that blade was holding the proximal fragment.
Yes, that was only the blade that was holding the proximal fragment, and that's why I really believe on cephalomedullary nailing, because the blade or the screw without augmentation is an extreme powerful instrument to hold unstable fractures. I really trust that blade or the screw to hold everything else in position. I really believe on the nail as the best implant to treat this fracture.
We all should take this as one of the tricks that is available for use if the situation demands. And with this, I think let's go ahead, Sunil. I think it's a great trick to know that it exists in our armamentarium. When we need it, use it.
Sunil,
Okay.
you have been always saying, do not nail the unreduced fracture. Now the nail is used for reduction.
It's one of the trick.
It's a reduction tool.
It's not a every time you should do it, but it is when everything is failed. When he was 14 years back, it was not the armamentarium or instruments were not available. So that is the time. But now he says the collinear clamps, the encircler wires, passers, everything will go to handy, and all the joysticks and everything is there. All right, Chetan, go ahead.
So go back to the history. Yes. So this is just a case to analyze. This is a 56-year-old farmer, not diabetic, came to me with an intertrochanteric fracture, which was fixed with a PFN, the old 2-screw PFN 6 months ago. He came to me because in spite of 6 months post-operatively, he was not able to bear weight without support. He was limping, and there was pain at the operative side on weight bearing. On clinical examination, there was no fever or any sign of infection locally. Next slide. Yeah. So I just want an entire panel of faculty to analyze, is there anything wrong in this? This is a 6-month post-op X-ray with which the patient has presented.
Can I
Start with Shushrut.
Shushrut, yes.
Yeah, I think I will do a CT scan to analyze whether this fracture has healed at all or not.
Okay, so you are doubtful about the healing, is it?
Yes.
Okay.
But can you see it in the metal inside? You get a lot of artifacts.
but still we should be able to see some plane of cleavage if there is a non-union. And that's my best guess for the pain. He has only pain, right? Infection
Yeah,
ruled out.
and an inability to load it.
Yeah. So I think my best guess at this point in time is non-union. He's walking on the nail. Evaluate it by doing a CT scan.
Anything
Yeah.
else? Anyone?
Can I say something, sir? Sunil?
Yes.
Yeah, sure, Naveen, go ahead.
Yeah. Can you see that it is the instability is going on? It is going gradually into the virus. And on a toggling, this screw may go inside. On a toggling, this is a sign of instability, clear-cut sign of instability, and it may go in or it
But
may
why
get
do you-
hedged out.
Naveen bhai, why do you think it is unstable? Because the surgeon has done
because
everything.
surgeon has done everything, but still the lateral wall is not fully constructed. And on weight bearing, this axis has changed. If you see the axis, it is 130 degree, but now it has become to 125. So,
Okay.
the axis is blocked. Now no further collapse. Either the screws will go in, it is medial migration, or if it is a loose, it will go into lateral migration and it will fail.
6 months. It is 6 months.
6 weeks.
Like 6 months.
6 months.
6 months, okay. Then it will hedge out, or either screw will
But
break.
that's not hatched out.
Either screw will break there.
What,
Yeah, there are only 3 possibilities with instability. Either screw will break or there will be migration.
1, 2, 3, 4, 5 possibilities, all related to non-union.
Tell me honestly, because he is presenting this, there is supposed to be some problem. Otherwise, you
No, because there is a pain, there is an instability. It is an invisible instability which we see only on a static X-ray as a stable. But if you do a dynamic thing, anything, it is on load bearing, cyclic loading. It's not healing. That
See, to
means
be-
there is a macro motion is going on.
To be honest with you, when I saw the X-ray first, I didn't think there was anything wrong or abnormal in this, except I agreed with Shushrut that this was not healed or not healed well enough for 6 months, and therefore he was having pain. Was my thought process. Anything else, Tanna sir or Babulkar sir?
No, I think at this stage, unless, as you said, since you are presenting, there is something wrong in here. Otherwise, I would have waited for this.
Yeah, because the index surgeon had also told him to wait. Let's go to the next slide, Sunil.
Wait, Paulo, what is your view?
Paulo, yeah.
I agree with you, Tom. The X-rays, I can't see any sign of loosening of the implant. The nail is strong enough to hold the power of an ununited fracture for years, maybe. But my first option would be some problems of healing because of the pain. But with 6 months, I would do some image studies to try to understand what is going on. But to be honest, I don't see anything unstable of the screw fixation proximally and distally. Image was innocent.
All right.
So this is just a better AP view, which did not really make me think that anything was wrong here, except I was just suspecting in the back of my mind was what Shushrut said, that probably it has not healed enough. And
But there is no support in the lateral wall to these screws.
That doesn't give rise to pain, Naveen. Never.
And
That is
6
the
months,
instability. That is the
Unless
instability. That is the,
unless
in 6 months, it should have failed by now if there was no support.
exactly, if 6 months have gone by, if
Yeah.
something was wrong, it would have really been gone haywire.
Right. So,
only possibility is probably low grade infection then.
but there was no local sign of infection. I did his CRP, ESR, everything was normal. The index surgeon told him to wait and watch and gave him teriparatide, etc. I was really confused, to be honest. But then since he had pain and he was not able to walk without the walker, I advised him revision, which he refused because after hearing the budget of revision, and went away. He returned 1 month later with this
non-union.
Yes, this has to happen. This has to happen.
So why did this happen? Why?
Non-union.
Because there was a point loading at this hole. there was a point loading. It was in the fixed angle. Now it was not a collapsing device. It has become a fixed angle device because of the collapse axis was fixed from 130 to almost 120 or to 125.
Paulo,
Uh, as I said, the nail is strong enough to hold this for many weeks until it heals. And why it fails and varies? Because no posterior medial support. And it always breaks in the first hole. The nail was good, it was holding, but the fracture didn't heal. But that the X-ray for 1 or 2 months ago was innocent because everything wrong is happening inside the nail.
right.
Maybe in the future, with the smart implants, we can check the tension of the nail by our computer. And we look, it's not going to heal. The nail is under too much tension. Let's going to do the surgery. But today, this is not commercially available. And it was a clear implant failure for non-union because of no medial support. That's what I think it happened.
The future is stress
Wait,
sensing implants. Stress sensing implants.
Shushra,
Yeah, Chetan, if that patient had pain and if your CT would have demonstrated in some plane of cleavage non-union, he was walking on that non-union. The weight was borne by this implant. That's why it broke. So
so
the
rather,
fancy words of fixed angle construct, whatever is, I don't know. It
no,
was a plain simple non-union. He was walking on the implant. It broke.
I totally agree with you. I also concluded from that previous X-ray that this has not healed and he should revise it. But he did not revise it. He went away and he came back with a broken nail. Now what do we do?
Okay, Dr. Babulkar sir, what do you want to do now? It has
Now, go down, take out the implant, excise the fibrous union, and
Yes.
fix with 95-degree angle with bone grafting.
Angle weight plate and bone graft. Okay.
95-degree angle plate and bone graft.
okay. Gadegonde sahib?
Actually, container blade plate is good, but I can revise with the long PFN also. It's because this is a reconstruction nail. You can see the screw size. This is a similar screw size. In PFN, you have a larger size inferior screw and superior is smaller size, and it is a straight nail. So you can change the this entry point for PFN through piriformis fossa and do a bone grafting. So exchange nailing with bone grafting will also do in this case, and probably it will help this
Will
anterior.
you have, sir, will you get a good hold in the proximal fragment? You already have 2 tracks there.
That's through that tracks also, because these are the smaller screws.
Dr.
You are
Gadegonde,
putting a larger screw through that.
Dr. Gadegonde, this is
Yes.
a non-union which requires absolute stability.
Yes.
We'll have a augmented plate.
So you
Augmentation of the plate on the lateral side.
Yeah.
nail and plate both should be
The combination
should be, because alone nail will not give any absolute stability
along with bone grafting.
along with bone. Yes, Paulo, you are raising the hand. Yeah.
I think we can go for a re-nail, but I think for this case, depends on the quality of the bone. I would go for a valgus osteotomy and a lot of compression, and I use a little bit of bone graft that I can remove from my osteotomy. Valgus, blade plate fixation, and a lot of compression to get absolute stability for this one.
So blade plate.
You said
Tanna, sir,
only nail will give you the absolute stability.
No, I don't think we can't have absolute stability with the nail. My major problem with the nail here is to get the perfect entry point and hold it in valgus position to avoid refixation with this one. A nice combination is a nail and a trochanteric plate before we insert the nail. It's a very nice technique. We get the valgus, reduce it, and then we insert the nail. It's a very nice, but I think that the plate is enough to correct this one. Because now it's a subtroch.
This is lateral.
I will, can I? Sunil,
Yeah, yeah.
Yes, sir.
Yes, sir.
I will feel here. I'll do the renailing, refashioning the things into the valgus position and keep the valgus position by a hook plate. So I'll put a hook plate onto it and put in lots of medial autograft.
Okay. All right.
Sunil,
Your choice, sir, would be nail and plate both.
That's right. That's right.
Okay.
Sunil,
But
Yes.
hook plate, I feel the trochanteric plate, it doesn't
Yes.
take anything to the trochanter, because the trochanter, once you have a hook plate, you're pushing the trochanter down, so you are neutralizing the abduction force.
Right.
Sunil,
Yes, sir.
excising the non-union fibrous tissue after removal of implant would be important step. Plus putting a graft into the medullary cavity, cancellous graft, and then doing a quick angle blade at 95-degree with a rigid compression, and then bone grafts again.
All right.
Okay, so just go ahead. The patient, I decided for a proximal femoral plate, the Smith-Neveu variety, which gives a good hold in the proximal fragment, but then the patient could not afford it. So I used a distal femur LCP of the opposite side. And just go one slide back, Sunil.
One slide back.
Yeah, so I revised it. I tried to get as much contact possible after freshening the ends. I bone grafted it and gave a good rigid fixation. And next. So this is at 3 months, he was walking with a stick. And one more, next. This is at 6 months.
You're lucky.
But it is in Varas, Chetan.
I agree that it has collapsed into Varas a little bit, but this is the best I could do.
What you could also have done is put an anterior tiny plate,
Yep.
or and also fibular strut graft. You already have a canal there, intramedullary.
Yes.
Put a fibula inside medulla and an anterior plate. And one additional anterior in a different plane would have given you an additional absolute stability.
Okay.
Couple of days
And
back.
as I've been talking about, this virus is because the trochanter has an
Yeah.
abductor force which is working. So every time I have put in a hook plate,
Yes.
this has never happened. Somehow the hook
Or-
plate,
Or he could have added tension band wire with the abductors. That could have prevented that virus.
Sunil, you are
now,
going forward.
Okay.
now I think we are, I'll butt in at this stage. We are only saying that the fracture is united. He is a young man. The function of that is going to be an abductor lurch. There is an abductor weakness, and there is going to be a fatigue on walking long distances. Though the fracture is held up for us in the meeting, we will talk about the healing of the fracture. But as far as the patient is concerned, he is going to have a very comparatively deficient walking, but he'll walk about, he'll be grateful to Dr. Pradhan, and he will not realize what else could have been done.
Yeah, he is 56 years old. He's a farmer. He's doing everything.
56 is very young.
I know.
Anybody younger than me is very young.
85 is younger.
Sir, may I ask question?
Yes.
Chetan,
Yes, sir.
you think that this is the ideal implant for this type of a fracture?
No, it's not ideal. I fully agree. I would also use a nail with a plate on the lateral side if possible today. Or my first choice ideally would be a proximal femoral plate, the Smith-Neveu variety, which is slightly costlier. It costs about 75,000-80,000 rupees, and to which the patient was not willing. Therefore, I had to use the second best option, which is this.
All right. Now we were a little bit change of the yes, Paulo, you want to speak?
Just one question. Do you have the complete set of the blade plate available in India? It's easy
Yes.
to get it.
The Indian variety, yes.
Synthes has not stopped. They are stopped.
The Synthes
Okay.
has stopped, but we have the original Synthes instrumentation set, but the implant is Indian.
Yeah, no, here it's very difficult to find the original ones, but talking with the Synthes engineer, they said that the blade is still on manufacture. That is not true, that discontinued.
Yeah.
And then I asked, so tell everybody because we just can't find in the world.
Okay. Now we are little change of the situation. Naveen will take over for this video presentation. Can you take video, Naveen? Naveen?
Where is his voice?
Naveen, you can't hear. Can you?
Okay. I unmuted.
Yeah.
Okay.
Female 56 years, 80 kg, failing DHS. Lateral wall is broken and there is a discharging sinus, probably due to this irritating screw. What should be done now? Sunil?
Yeah, I will remove the implant because it is unstable. We
Yeah.
have deprived that sinus tract, and then
So-
I will take a CT. Once you are removing that, I will not put in immediately. I'll wait, give some antibiotics cover to that, and then afterwards, once everything is healed up, then I will realign with the two plates, because I will do a CT. We'll see what is the situation of the lateral posterior medial wall.
CT says that there is no union.
No
As
union,
such,
but
yes. But what are the geometry, fracture geometry?
fracture geometry, the posterior medial fragment must have united. It is already how many months old?
It is 3 weeks, 3 weeks only. 3 weeks only.
Okay, so it is not united. So we will just realign it into valgus and fix it. If possible, I'll add an anterior bridge plate to give.
So you will use extramedullary implant, 2 plates, one the lateral plate and one orthogonal anterior plate.
Right.
So Surut?
So once you decide that this infection is not active, then I will remove this.
It doesn't seem to be. It doesn't seem to be infection, but it looks like an irritation of the fat tissue.
So if it is active infection, then I will do 2 stage. But
No,
since
doesn't look to be active infection. All parameters are normal. Investigations.
So
are
my
normal.
single stage would be take out the implant, assess the posterior thing. This is a lateral wall deficient fracture. Choose a intramedullary device and use a hook plate kind of a thing to pull the abductors down and put it on the lateral side. So intramedullary nail and a hook plate to take care of the abductors and the posterior wall. So it will need lateral wall augmentation in this. And while reducing, make sure that this inside calcar goes out of the intramedullary canal to create a positive reduction. This is a
Positive
negative
reduction.
diamond used.
Already the big DHS has gone inside the bone.
Yes.
So if you want to put in a nail, we'll again give a loosening of that bolt because it's not big bolt.
Helical blade will give you
the
purchase.
lock plate.
Helical blade will give you purchase. Not to worry. It will go in the.
Dr. Polo, what's your opinion?
Just want to make 2 comments. There was one study going on here in Brazil by the public department, would be irrigation debridement and reduce the fracture in valgus and fix with the cement base plate. It's the same DHS, but with 150 degrees. It's covered by antibiotics with the cement. It's a 1-stage correction. This is one study that is going on with very, very good preliminary results. What I would do, irrigation, debridement of this one, remove the implant and do 1-stage fixation with the nail. But in order to do that, I would go with suture. I would do a CT to see if I can't put a blade. Looks like on the picture on the middle, there is enough space to put a new blade anterior to the previous one. So that would be probably my option. Let's say the head is destroyed, I would go for a blade plate.
Babulkar sir.
After the control of infection, I will go down, do another debridement, reconstruct the lateral wall, and fix with 95-degree angle blade plate plus additional anterior plate and bone grafts.
Okay, Tanna sir.
See, this is the lovely beak which is there.
Yeah.
This
Good beak,
patient,
yeah.
if in case it was done primarily medialization like this,
Yeah.
and a shorter plate, then probably this would not have occurred. And a short barrel plate and a shorter screw, this would not have happened. So today, I think if the screw is in the center which in the AP and lateral, if I can see, it is in the
No,
center.
no, no. Lateral, it is just going to pierce the cortex, antecortex. If you see
So
here,
if it is not in the center, I will remove that screw.
it is not. It is not in the center. This is the head shape,
Yeah.
and this is the
So
neck
then
shape.
I will fill up that track with a bone graft, and then I will put in the short barrel DHS and put this beak very properly inside in the distal part, and then get a perfect valgus reduction with 140-degree plate. And I feel that I'll have no issue at all. The patient will be able to walk about. Obviously, I'll put in a tension band for the trochanter, and this is what I would do it at this stage for this patient.
Okay, sir. What we have done is, we have used our implant assembly with the nail and plate. These are the intraoperative images. You can see the nail and a plate, where the screws are going through the plate to the nail, and the distal screws are also going through the plate through the nail to get a one single implant assembly. And this is the post-op, immediate post-op. And we have added a bone graft with Venco and meropenem, just because of the fear that probably it may be an infection. Now, what is the comment? Here, the reduction is negative, as you see here, probably.
Why did you accept that?
You accept it because this was the only possibility. What do you think?
You could not get that.
Do you think it is a negative reduction at all?
It is a negative reduction.
Okay, we'll see subsequently.
Negative reduction doesn't mean a non-union.
Yeah, yes. That is the message. Oh my goodness, how it has gone front. Some slides are not copied.
Fine.
Then I want to show the result later on. What happened? Right? Now this is at the 6 fix, sir. Do you think it is a negative reduction here? Do you think this is a negative reduction, or this Sultan's line is okay? Because this is a comminuted fragment, not of that big.
Naveen bhai, may I interfere?
Yeah, yes, sir. Yes, sir.
It is a rotational malalignment. You find the lateral X-ray. There is an anterior translation.
Yeah. Yes.
And
Yes.
this is the gap. It is only because of that rotational malalignment.
Okay.
And this nail is not through the proper entry point, and even plate.
There was nothing laterally. There was nothing laterally. It was total deficient.
There was a bone here. You can put it this. You can put the nail from this place.
More medially.
No,
More medially. What is there?
No. It was not possible from here.
Yes,
Very
yes. You
thick
can
patient,
say that
yeah.
it was not
Yeah.
possible.
Yes. That was the possibility. Yeah, you are right, sir.
Please go ahead.
Yeah. Now at the 12 weeks, you can see it as a beautifully uniting with a minimum collapse, with a complete lateral support. Gradually, it is uniting. And this is at 2.5 years, the complete consolidation on the medial side.
So what is your take-home message?
Take-home message, it is a stability which is required. Positive, negative reduction, but with the stability, even if the negative reduction is there, the stability takes care of that part. Only when there is an unstable, that negative reduction goes into the virus. If the stability is good, it doesn't go into the virus.
So nail and the plate combination is the function.
That is the possibility in case of the instability. Now let me another case of the PFN. The lateral wall is very, very thin. You can see here. Even with the nail also, the surgeon has done the nailing like this. Is it okay, sir? Gadegone, sir.
No, it's not okay.
Yes. What is the problem?
That is the entry point is through the fracture side. There is
Yes,
a wedge
yes,
effect,
it
and
is-
there is
yeah.
a varus. Your inferior screw is superior.
Do you feel it is a virus?
Yes,
It is
yes.
a virus.
Yes,
Yeah. Slight virus is there. Slight virus. Is
AD
there.
distance is not maintained. There is excessive antiversion. There are so many things.
What will happen?
This is cause a wedge effect. What is called a wedge effect created by the trochanter
The
part.
proximal nail part. It is a wedge effect, right?
And
What is
proximal part of the nail has no hold at all in the bone.
Yes, yes, same. It should go from here, or either we have to rim this part to prevent the virus. We have to rim this part, the nail should go from here. From here. Right, absolutely. But what will happen?
If the God is great, it will heal. Otherwise, it will fail 100%.
In what way it will fail, sir?
There will be a migration of the screws, lateral migration of the screws.
So
will
Z effect or reverse Z effect?
Yes.
Z effect or reverse Z effect?
Anything can do, but to Z effect, reverse Z is the more possibility.
Okay. Reverse Z means one screw will go in and one screw will come out. Superior
Yes.
superior will come out and inferior will go in.
Go inside.
Okay, Dr. Paulo?
You already mentioned the screw is too short. That's what I said on the lateral view. It's clear that there is a kind of rotation. I don't like two screws. I like just one single screw on the femoral head, but I think it's too posterior. Can fail as cut up.
Right. Now,
Go ahead.
both screws is migrated laterally. No reverse Z or Z effect. It is both the screw has a lateral migration. So there is nothing like a reverse Z or Z effect with the two elements in the neck. It is our visualization. One goes in, one goes out. Either it is a medial migration or a lateral migration. It is our visual effect. So we describe this phenomena as a lateral or it is a Z effect or a reverse Z effect. But both may get migrate laterally. Then it doesn't fit in any phenomena of Z or reverse Z effect. Even with the single implant,
it only means there is unstable.
there is instability. That is the message. There is invisible
Z
instability.
or reverse Z is in all the signs of instability. Nothing else.
Nothing else, sir. Absolutely correct, sir.
Sir, may I interrupt?
Yes, sir.
These are all three: medial migration, lateral migration, Z effect, reverse Z effect indicates only one thing, that is unstable construct.
Yes.
And quality is poor. That's all.
Yes,
Where
instability even after the fixation, right?
Yes, sir.
It was revised with the nail and plate, and it has given a good effect.
Sunil, time to move on, man.
Yeah.
Yeah.
Good.
This we have done the finite element analysis where you can see on the toggling of the nail.
Naveen, we have given
yeah.
4 minutes
Okay.
already over. We are going ahead.
Okay, with the single implant also in the neck also, if it happens like this, it's the cut through.
Please shift the screen, please.
Yeah, okay. So, thank you, Sunil. Can I take a leave because I have to join other webinar?
Okay.
Thanks to all. Susrup, thank you.
Thank you.
I will leave.
Thank you.
Okay, thank you.
Yeah.
I can't see me.
You just share green button lower down to share in the middle.
Where it is at?
In the middle, lower middle.
Share your screen.
Yeah.
Share screen.
Yes, he has
shared
done it. Go to the PowerPoint lower down. Go to the PowerPoint lower down. Just near the word.
Yeah, okay.
Yeah.
That's what I don't want to interrupt in between.
Full screen, huh?
Anyway, so the shattered wall cause a major instability, which we have come to conclusion, important as posterior and posterior medial fragment. Buttressing prevents and nail prevents collapse. We will have to discuss this. I strongly feel this augmentation is must for all the fractures. The rationale is all unstable fractures need stability. All fragments are fixed. Lateral wall, posterior medial wall reconstruction and early mobilization is required. So whatever the things we can augment, we can see it later. What is the thing we can do it? So reverse oblique, we are mostly we are discussing here because we have less time now. So I hand over to Dr. Babulkar, Sudhir Babulkar sir, to take over his case.
This was a young 45 years male with a reverse IT fracture.
Yeah.
And we did a CT scan. Can you go to the next slide? This is a CT scan. You can see it's a big posteromedial fragment plus exiting at the lower level, typical for reverse trochanteric. What do we do now?
I think this is a very nice fracture. We see more and more the reverse obliquity nowadays. And in my opinion, this is one of the best and clear indications for a close reduction and fixation with the IM nail, the one that you are used to use. I use for this type of fracture, the reverse obliquity. I tend to use the long nail, and I use the single head element for fixation. And as I said, I do this in a fracture table. And this is a good, the CT on the right, there's a very good reduction tool that is the collinear clamp or the clamp. So what I use is I put the collinear clamp, I get the fracture reduced, and then it's a straightforward nail. I really like this reverse with IM nail, short, long ones.
What about the posteromedial fragment?
The way I think the posterior medial fragment, to have access to it is going to be a lot of an open reduction, a lot of devascularization. Even by percutaneous, I can reduce, but I can't fix. So in my opinion, the nail is strong enough to hold the absence of the posterior medial anterior hill. So usually I don't fix it. I leave the nail, but I want a valgus reduction. I don't accept a varus reduction, and must be a very nice fixation of the femoral head, with or without augmentation.
Realizing good communication, we use the circlage wire with our technique, temporarily reduce, pass a guide wire, rim, and put a PFNA. And then subsequently, after putting a nail, tighten up the circlage wire. One circlage given superiorly holding gluteus medius, so that the greater trochanter does not fly away. Comments?
Sir, may I comment?
Yeah.
Sure.
You can see here the nail is the neck is retroverted.
We try to connect with the circlage wire. So still it had sag. Can I show you the next X-ray after circlage wire? Sunil?
Yeah, this is one. This is the X-ray.
Post-op CT scan.
Post-op CT scan. Yeah, this is post-op CT scan.
So this is showing you, Vadagonas, sir, there is no retroversion of the neck, of the head, CT.
Okay.
Can you realize this? Figure 5. It is nicely fixed superiorly and inferiorly, holding the base of greater trochanter.
Anybody wants, Chetan, what do you want to comment on this?
No, I also routinely do a figure of 8 kind of a transabductor wire loop in such fractures. What I want to ask, sir, is why did you do a post-op CT scan? I mean, just for a study purpose, or you routinely do it?
No, not routinely, but the patient was young, high demanding. We wanted to be very sure that all the fragments has been fixed properly.
Now, can I answer this, Chetan, for you?
Yes.
When I was trying to design this figure of 8 loop, I wanted to see whether my single loop, which I was doing in vivo, is reproduced exactly in the body or not, whether my single loop is engulfing all those fragments which are posteromedial, which are anteromedial, and the lateral both or not. So these are the first 10 cases I did. I demonstrated that it works. And so this is one of those patients.
Routinely, we don't do.
I have also been doing this figure of 8 right from the DHS days. You take it across the abductors, and the same loop what you have used, exactly the same. I mean, what is the need for that superior loop?
This is one singular patient when I realized that some portion of abductors, muscle portion, was avulsed from the greater trochanter.
Okay,
so this superior loop is not used in the rest of the cases. This is one singular case.
Routinely, you would not do that.
No,
And the
no, 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 no.
virus is, and the virus is always accepted, is it?
The virus is never accepted.
Now here there is so much of virus there, post-op.
See how you see it?
Post-op virus, there is again, as I'm saying it again and again, the patient will have a limp, patient will have a fatigue, he'll not be able to walk for a long distance because of the virus, but he'll be walking. I think this is all the time we talk about the fracture is united, and I've been talking about in the meetings. I work in the richest part of the country, and if I end up in a result like this, I think the patient is going to be very, very, very unhappy.
I'll tell you this patient story, sir. This patient is owner of Indorama. So he is one of the richest in the country, this guy.
No,
So I did the CT scan.
patient now.
Doesn't have any abductor lurch, doesn't have anything. So
Anyway,
he's
I
good.
buy your word. Sure.
Yeah.
Tanna sir,
If you
what
think
would you,
this is no virus, okay, fine. We proceed further.
no, Tanna sir, how would you correct this virus then?
It,
This case, I would have done a 95-degree.
Okay.
what I think that I'm the only one here that have a different thinking about the circular wire, and we did some studies. It works in a model, but in human life, I'm not truly convinced that it is helpful at all. What I do on these fractures, it's trying to correct the valgus at any form, open or closed reduction. It needs to be in valgus. Second, if it's a reverse fracture, I always go with my entry point a little bit more medial. This fracture, it was a huge piece of the greater trochanter, and it's going to heal. If you correct, you get the nail more medial to hold the whole greater trochanter and a very nice fixation in valgus. I'm quite happy with the results that we have today regarding the motion and
Sunil, can you go back one slide? Go back.
This one you want?
Yeah. The fracture is healed nicely, though there appears to be coxa vara, but the fragment have healed laterally, medially, both, and anteriorly also.
All right.
I'll quote one case. Can I?
Yeah, sure.
Sure.
High police inspector in Ahmedabad. He had this sort of a result. Some of you might be knowing that case. And he has filed a huge suit onto the surgeon because as a police officer, he could not function. He could not walk properly. He couldn't run. He had a very, very short fatigue time. And ultimately, I remember I saw him professionally, and it was also seen by in Jamnagar by
Yeah.
other doctor. Oh, sorry, kya naam uska?
VM Shah.
VM Shah. And ultimately, he underwent a valgus osteotomy after the fracture is healed up. A valgus osteotomy. And once the valgus osteotomy was done, then he said, okay, now I'm perfectly normal. I can run about, I can move about, I can do everything.
All right. So this is the patient. We will go ahead. Where circular wires about this. This is a 98 years old man came to me.
98.
98. And this was a CT scan of the same. So our joint replacement department say, oh, why do you want to put a nail or plate or something which you want to, but this, when you see the posterior medial, that was Paulo, you just see the posterior medial, a big, huge, and I operated on with the augmentation, and Sushrut, we started doing this, and 95 angle ball. So what I am going to show you, some sort of a percutaneous way of treating. Because of waste of time, I don't want to show the details, but the use of a encerclage wire loop, which gives excellent stability without damaging, without taking any extra incision. So what myself and Sushrut have been trying to convince people that this tension band wire is an excellent augmentation method which can be done easily by everybody with the reproducible results. It's not at all expensive, it is very cheap, and you can just pull it from master the technique. I can give you the video on the sawbone, but less time, we can just keep that because it is a little bit more. So while doing this, we just fix it with this fixation, and once all the intertrochanteri wires, everything is engulfed, you can just compress this tensioning, excellent tensioning device, and then you can get a good view of the tension band with the small incisions which are made for the incision of the plate, I mean the nail, as well as the bolts. And we have published this in myself and Shushruth in Injury, so that we can go through this article, anybody wants to go. Now I again come back to Paulo for his second case. Paulo, you want to comment on this?
Yeah, you gave me that paper, and then we had a very good breakfast discussion about it. So probably is not my case. Is this white? Let's see the.
Okay.
Oh yeah. So yeah, can you? That's a engineer that had a high-speed bike accident with this fracture, and this in order of the time, I'm gonna make a little bit of the comment. And it's a IT fracture with a subtrochanteric extension. And you can see that the lateral wall is gone here. It's totally detached. So it's a fracture. Can we go one slide more? So that's what the X-ray, the plain X-ray can tell me. Can you just one more? That's the big femoral head and neck, the posterior medial that's gone, and the lateral wall and the shaft. So what would be the options of you guys?
Yes, Shushruth, go ahead.
I think reduction is the key here. Once you reduce, my option would be an intramedullary implant, and I would put a couple of cerclage wire. So one cerclage wire which will wrap it around this, and one more circular loop which will engulf this posterior medial lesser trochanter and the tip of the lateral wall. So one figure of 8 holding the greater trochanter up there, and one more circular loop which will go at the bottom to close it.
A short nail or a long nail?
Long nail, of course, long nail.
Chetan?
I would also do a long nail with a slightly medial entry, so piriformis entry nail, a long PFN-A2, and a single figure of 8 loop.
Reduction with the loop or trochanteric or lateral?
Lateral. I do it in lateral only. But I would not hesitate to do a mini open reduction if I am not happy with the reduction.
Okay.
Paulo, Gadagone?
I will take the patient on fracture table, reduce the fracture, and I want to do a primary treatment is the nailing. Decision of augmentation will be after the fragment specification as well as the stability of the fixation. If the fracture is stable, by doing only nailing, I will keep it like that. If the fracture is not stable and reduction is not holding properly all fragments, then I may go for augmentation, mostly by plate. I don't agree that the cerclage wiring is a minimal invasive method, because you are able to do it, you are expert people, but I have seen mess of doing the cerclage wiring in such a high volume of the thigh structure patients, because you have to put cerclage wire superiorly as well as on the medial side. So you have good instrumentation that for add expertise, you are able to do it, but I will open it, see the lateral wall, and probably I may augment after doing the nailing.
Yeah, that's very interesting and an important topic, not to create more damage to the patient.
What I will do is to convert that lateral wall fracture with the one lax trochanterus, and then I will reduce that, the peak of that trochanter coming down for the, because that will be get anatomically reduced. If it's a spike, will get reduced anatomically, and go into the valgus, put a long conventional two locking screws, like a old PFN, long PFN. I used to do with the one blade, but somehow I feel rotationally it is unstable in such a devastated fracture. So one blade is not enough. So I started using again back old PFN with the two locking bolts. And one small augmentation, which myself and Dr. Gadegone are doing, is we're doing the publication with the multicentric study. So we will be showing this. I will show you what plate I'm going to use after everything is fixed. Just give a additional lateral support, which is a very simple plate, not expensive at all. And then we will see the results. Because in spite of putting a tension band, even plate, this fracture tends to fail because it's an inherent instability itself.
Sunil,
Yes, sir.
I will reduce this fracture on a fracture table. Temporarily put one circular subtrochanteric region and one K-wire superiorly from the greater trochanter to the head. Once I am satisfied with the reduction, I will put a PFN A2 and additional circlars, tighten it up at the subtrochanteric level and put a screw in the upper part, greater trochanter, into the head and neck.
I will add up. Can I, Shushrut?
Yes, sure.
Sunil, can I have?
Yes, sir.
I will do more or less the same thing, but the beak of the GT which is there, which will not fit in all the time onto the lateral part which is there with the PFN alone. I'll do the PFN, as I said, from piriform fossa, and I will supplement it with the hook plate because I feel this is too comminuted a fracture to take a chance. Slightly extra surgery doesn't, I feel I am not bothered about it. So I'll put in a hook plate there, which will be holding the trochanter beautifully down below. And this is the one which I will do it all the time.
All right. Shall we go ahead, Paulo?
Yeah, can you move on? This is a very nice view and very interesting comments about how do we see this. And as I said, I do on a fracture table, but not in this position. Can we go ahead? Because I'm using the long nail. So if I use the long nail, just one more. If I use the long nail, that's the position we call the Caesar position, because I can have the perfect AP and lateral view proximally, and I can move my image to get the distal locking without the other leg blocking the way. It's a very nice view for proximal and the distal. Can you just move on? And this is, you already saw the indications, but my concept is to get the tube together, not to fix the abductor mechanism. Can you just go one more? And this is what it did. We can see where the cerclage is to connect the lateral fracture to the medial one. I'm not intended to get the posterior medial together. The tension of the soles is too high. It's usually too medial. There's the neurovascular bundle close to that, and I don't want to go there. So my idea is to get the tube together, and once I have the tube together, I can put my nail. And I go a little bit more medial than usual, not at the tip of the greater trochanter. That would be a little bit more lateral. So that's my indication for this, and I always use a long nail. We have a problem here in Brazil. We don't go by 10 millimeters, we go by 20. So the next one would be too long, and this one, in my opinion, is short. I want to go really, really long underneath to avoid stress fractures down there. So that's the post-op, that's the immediate post-op, 2 weeks down the road. So any comments?
Yeah, this cerclage wire, small wire, is, I have seen so many failures in spite of doing this. We need to reconstruct that posterior medial wall, and it is not difficult at all. You can let it, what will happen in few days of time, or once patient starts walking, it may break, but it doesn't matter. It will get sticky meanwhile to the give support to the posterior medial fragment.
Exactly, Sunil. So if you put two loops, so one is figure of 8 to close that lesser trochanter, and my second loop, which is exactly this. If you put two, this will make it a stable construct. Yeah, that's what I was saying.
In my opinion, the wires are reduction tools. They are not fixation tools. I rely everything that I'm doing on the proximal part of the nail, the stability of the blade inside the nail, and the stability of the blade inside the femoral head. That's what we call it, the cephalomedullary nail. We don't care what is in between. I need a very nice fixation of the femoral head, a very nice distal locking, and what is in between, I rely on the metal.
But this,
Those templates for me, it's a reduction tool to get the tube together and not a fixation device, not trying to get anything else. And that, as I said, the results after years doing that, the posterior medial fragment doesn't look for me as a problem, except in simple fracture and in non-unions.
And this posterior medial fragment, when you try to fix it up, it is a radiological fixation. It doesn't genuinely go back into the posterior part where it belongs. It is a radiological medial fixation, which is not going to give you that stability what you'd expect it to give.
No, I don't agree with you, sir.
I feel like what you comment, because if you want to give support, you need to go there and put anatomically and fix.
Exactly. Exactly.
That's my opinion. I agree with you.
There is a soft tissue interposition. If you keep that fragment away from the bone, that will never give you support. That's you. I will agree partly with Paulo and sir that this may not go into the same as anatomic position, but at least it will be near to the bone, which will eventually heal. In this position of 2 centimeter of gap, it is not going to heal. Fortunately, sometimes it may heal, but it will give many times. I have seen failures in reverse oblique fractures with single blade without augmentation. That's when we started doing this, this is the only way we can just help biology to help. If you keep that fragment away from the bone, it is never going to unite. And that gives a lot of problem.
Have you ever seen a non-union of the lesser trochanter?
Yes, sir. Happens many times.
Hardly ever. Hardly ever.
Virus, it goes into virus, it breaks. That is what?
So
anyway, proceed.
Let's go. My opinion is that the first case I showed, the nice healing of the posterior medial, and it is a big chunk of fragment. Can you move on? Can you? So
that's right.
It gets in because this is a very well vascularized area, and
exactly.
It gets in. It's sucking in. For my opinion, what we need to have is the anatomical axis restored. The neck angle, the alignment on AP and lateral, that's what we need. Where the fragments are, I don't care. Okay, just one more. So that's a patient at 6 months.
Can you share the similar failure case and what is the analysis of failure of that case? Similar blade plate, similar reverse oblique fail. What is the analysis of that fail? Paulo?
I didn't understand the question.
So similar case, if you in your armamentarium has failed into a varus and broken implant. So what is the reason for that? You are doing everything, then mechanical access.
To be honest, the fracture that worries me, that scares me, is the simple fracture from trochanter to the lesser trochanter with a big piece of the posterior medial wall. That's simple one. That's the one that scares me.
Okay.
And fix it with the plate. If it fixes with the plate, the posterior medial part of the bone is much more important than when we fix with the nail, because it's a centralized implant. So that's the one that worries me.
May I?
And if varus, lateral plate in simple fracture.
So may I interfere, sir?
Yeah, sure.
Yeah, of course.
Actually, the property of the nail and to make the proximal, the part of the nail broad is that it will compensate for the posterior medial fragment. So it has a property that it compensates for the posterior-medial wall. And therefore, in a nailing, you need not worry where is the trochanter, whether it is medially placed, posteriorly or laterally placed. It does not matter very much. Failures of PFN with single or double screw, they are mostly occurs because of the shattered lateral wall. Therefore, if you are doing a nailing, forget about the posterior medial structure. If you want something to augment, is on the lateral side. Otherwise, a nicely done intramedullary nail with good cortical contact and good quality of bone, single nail will suffice. That is my observation.
All right. Dr. Babulkar, sir, you want to comment?
No, it's all right.
All right. Shall we go ahead, Paulo? Paulo? Unmute, please.
So that's the reduction techniques menu again, traction table, circulage wire. So it's a combination of methods on this type of fracture.
All right. So the issue of the small and short nail is no, they do always use a long nail for the reverse oblique fractures. All right. Why? I'll show you one case, because this is a case which we did with a short nail. Initially, we used to thought was short nail was better. Just we got this broken implant, and then we just replaced with the long nail. It got united. All right. So that is a long nail we almost use. This is a patient which I want to present now. Is a reverse oblique and a comminuted fragment. This is a CT scan. So who would wants to take? Shushrut?
Yeah. So show me the X-ray, please. No. Is this?
Yeah.
Okay. So this is the X-ray. X-ray obviously is also showing some shattering of the lateral wall, a postero-medial fragment there. Let's see the CT. So of course you have done the CT, which we have seen. So DHS is out of question because there is a vertical coronal split there. So my choice again would be reduction, intramedullary nail, and circage wire, and I can deal with this fracture. One single loop, it will close the entire all the bony fragments as one intact trochanter piece. And then once it is one intact trochanter piece, everything should be easy to do. So my choice, intramedullary nail and circage wire.
Gadevane?
Sir, this is the fracture which needs, in my view, augmentation because there is a coronal split. Anything you put, DHS is out of question, nail, two or single screw, it is going to separate because of the diameter of the screw. And therefore, this type of a fracture needs buttressing by anything as preferred method, circulage wiring or a lateral plate. So this is my take.
Chetan?
I'll first get that tube and reduction correct by doing a figure of 8 loop and then do the nail.
All right. Babulkar, sir?
To nail, in addition to circulage wire, I would like to do a 2-screw fixation, one anterior posteriorly holding the posterolateral fragment, and one screw going up to the calcar. So 2 screws augmentation plus circulage wire after the nail.
Okay. Paulo?
Probably I'll go for traction, close reduction, and a fixation with the short nail with the blade or the screw. And I don't remember the x-ray to see if it's a real bad quality of the bone. If it's a very osteoporotic patient, I might have the augmentation of the femoral head but it doesn't look too bad. But probably I would go for a single axis short nail like the TFNA or the gamma nail.
Short nail.
Yeah.
Short nail. Why? Why not long nail?
It can be, but the nail that we have is a 230 millimeters. So it's quite of an intermediate nail. And then I think it's strong enough for this type of fracture.
But you will not get an anterior thigh pain of the short nail.
The what?
Anterior thigh pain if you put a short nail.
Yes, that's why we change it. So the nail is now right and left, even the short ones. So to avoid the impingement of the anterior cortex. You're right. It hurts a lot.
Yeah. Anna sir?
Yeah, I think I will first put in a circlage there, and even after circlage, when you pass the DF, the screw inside into the head is going to split up that to certain extent. So even if you put a screw or a circlage, it's going to split up. So I would always want to augment on the lateral side, and I do it with the hook plate, as you know, because I think the hook plate I'm using it only mainly because the other plates are not yet recognized. They are not official plates. They are only the secondary plates which are available. But I will need an augmentation at the back on the lateral side will be a mandatory to me after putting in a PFA.
All right. So this was then I reduced this. What I was talking about after the putting a nail, I put this small plate on the lateral side, which is augmentation plate. We put one screw. One screw goes from that lateral to medial, and it's a 6.5 cancerous screw. And this screw, this screw which is gone into distal part will be exactly on the below, next to the spike. It should not be in a proximal fragment. It has to be in a distal shaft fragment. And once we get this augmentation plate, which gives excellent stability on the lateral side. Any comment on sir?
Sunil.
Yeah.
May I come? This is I doing it now regularly after seeing the Dr. Ganjale's result. Now there is a hole inside here in the plate.
Yeah.
So that put that hole inside the screw, and then you augment so that it gives added stability, and also it corrects the it gives added stability to the nail. So you can do that also in some of the cases.
I'll tell you why. Because PFNA blade does not have the extra something which prevents going down. So the PFNA blade, if you want to use the Indian 2 PFN, then it has got a big sleeve so that the screw can be passed through a jig. Even Naveen has devised that jig, 2 jigs through going through that screw, the plate and the nail. That once you that. But this is standard. You can put it for any augmentation plate. If you
No, I have a plate. I will share with you. There is a hole inside. So
I have a question.
I have a hole there, but it is not passing through the nail is not passed through that.
I have a question, Sunil.
Yeah. You are unmuted, Chandra.
You have a coronal split in the trochanter. Isn't your screw holding that plate going through that split?
Which screw?
I mean, the screw of the proximal screw in the plate, isn't it going through the coronal split of the trochanter? Does this plate really do away with the need for your circlage?
No. This screw I have put, this true screw is put to get the lag, what Dr. Babulkar was telling me.
Acha, so you have fixed the coronal split with these lag screws?
Coronal fracture is fixed with those.
Lag screws.
Stop.
he has put one anterior posterior screw to compress the fracture. That coronal.
Yes, right. I understood it now.
And Sunil, why is it in varus? I would have expected you to do a valgus reduction. Still, this is in varus.
Yeah.
Do you agree?
Sunil,
I agree. It looks like it's a little bit in virus. And let me ask you something, Sunil. This plate needs to be used with a special nail device because the collapse of the head element goes to this barrel. Is that right? Because if it's a conventional TFN or the TFNA, and if you want collapse, this plate is going to block the blade here. So this
That's right. That's
this
right.
is special nail.
Yeah, this is a this is a special plate. So till the time Sunil is not back, let me show you something which I have.
We
Uh, uh,
Dr.
What
Sunil
happened
is just
now?
connecting.
I am here. I did not do anything. What happened?
I think your internet crashed in between.
We just lost you, Sunil.
yeah, so I'll just take over in the meantime.
I'm here.
Sir,
join back.
can you hear me?
Yeah, yeah.
So this is the case, sir. Let me take this up. Can you see the case?
Yeah, yeah.
So this is the fracture. That's the fracture. Paulo, can you see the amount of comminution?
yes,
What would you do?
this is a tough one, but at least you can see the posterior medial here. It's longer than the other one because it's not detached. The major problem is the greater trochanter and the proximal lateral wall. This is a tough fracture to treat. My opinion, I would go for a nail. I do a traction. I reduce. Usually, I need a joystick, and I fix the greater trochanter to the head element with K wires, very anterior, very posterior, to get my entry point. Insert my nail. I fix it. Let's say if it's a TFNA, I have the guy to put the screws in. If it's a gamma nail, I go freehand and I add one screw posterior to get a better fixation. But and I don't have any experience with the cerclage. I think we can get the nail right in here, get a very nice reduction, and it will hold. Maybe if you ask me, this could be a great indication for this hook plate, or what Sunil just presented, a plate to hold the lesser trochanter down. But usually,
so till now we talked only about the lateral support, right? Gadegona sir, you will do CT scan here or not?
The CT scan is very mandatory here because there are so many only trochanteric comminution, not only trochanteric comminution, there is a medial comminution, anterior. This is a global fracture, and it is known as a this is a global. You can see here it is all over it is fractured.
So
And
what
there-
I call this is a type C fracture or a burst trochanter fracture, which we have classified on CT. So this typically has a big chunk of greater trochanter, but anterior and posterior wall is comminuted. So what I decided was to reduce this. Everyone happy with the quality of reduction here?
yes.
Okay. So that's what I did, Paulo. Paulo, happy with this reduction?
I'm happy. Maybe I could get the entry point a little bit more medial, but
Medial.
I'm happy.
You're happy. Everyone happy with the valgus which is restored, the bony contact? Everyone happy?
Yes, with the valgus and contact, I'm happy, but I would augment it as well.
Augment it as well.
But about the lateral wall,
Huh?
you can see there it is broken there.
Yes.
Okay. So so everyone will augment this for the lateral wall proposition, right?
That's
Yes.
right.
Yes.
Okay. Okay. So this is the the CT scan of this patient after the surgery. Again, everyone wants to do the lateral wall augmentation here, right? What I also want to show is this intact huge chunk of greater trochanter. So it's a different patient, right? Yeah. So again, everyone wants to look only laterally with only that hook plate sitting on the trochanter or a buttress plate going on the lateral wall. And as we went on, see how that DHS blade plate is still there. That's in 2 weeks, it started collapsing. and see how and why it's collapsing. Look at the anterior and posterior comminution. In addition to the lateral wall, of course, I respect your suggestion that in addition to lateral wall, we also need to look at anterior and posterior comminution. And in 2 months and in 3 months, it walked out. And of course, the solution is totally arthroplasty, right?
Yes.
Similar patient, another patient. Let me just take you through this patient. Exactly same patient. Anterior and posterior wall comminution. This time I was a little more wiser. Traction views, CT scan. Mostly that trochanter is intact. What I did was reduction, and I wanted to rectify my mistake of looking after the anterior medial comminution this time. So Smith-Peterson approach, which Tanna sir has taught me, and a calcar buttress plate. I neglected that lateral wall. This is one example wherein your thickness, diameter of the nail will look after your not so comminuted lateral wall. And you put a buttress plate anteriorly, you put a buttress plate medially, and it will stay despite of comminution. And you don't really need to support that lateral wall because this is a burst type of fracture. We also need to look after this. And it stayed and it healed. That's 4 months.
Because
So-
why it has healed? So,
because this time I looked after the anteromedial and posterior comminution in addition to lateral wall. Lateral wall was taken care of by the nail, the thickness of the nail, the right entry point.
that is anterior stabilization is the crux of your success.
Absolutely. So not always we only look for the lateral wall. We should also look for anterior comminution. That's the point which I was wanted to drive in. And
I
that's
have
why
done
CT scan is so very important, because a lot of times you don't see on an X-ray break in the anterior cortex. And that would render your trochanter still more unstable in some situations, especially in osteoporotic bones. Sunil,
Sir,
I
may
was
I-
trying to fill you in. Sunil,
All right.
I
So
will stop
you,
my share.
Yeah.
You can start sharing. Because we lost you, I wanted to take over.
I don't know what happened.
Anyway, you start sharing.
Sir Sushrut, may I suggest one trick?
Yes, sir.
After doing your nailing, what you
Ah.
should do through that incision, you just pass a finger and see whether the anterior wall is correlating with the distal fragment. If it is not there, because even after doing nailing, there is some translation. And in
Yeah,
that
yeah,
case,
I
you
agree.
don't
I agree.
hesitate.
I agree. I agree. But what I wanted to suggest is, in addition to cerclage wiring, you might need sometimes anteromedial plating also, and that the CT scan will demonstrate you.
Sushrut, can I suggest? This
Yeah,
is
sure.
Piles type 6. That means in addition to intertrochanteric fracture, there is an intracapsular fracture either at the base of the neck or transcervical.
That's a different fracture. That's called as a bifocal fracture. That's a different story.
Yeah, but then if you see all fracture was cervicotrochanteric, and additional plate would certainly give stability.
Yeah. Okay.
All right, Paulo, go for your third case.
Paulo, unmute, please.
That's a 90-year-old female. That's the same story. And if you can go for the next one. That's again the fragments that we can see on the AP view. But now we have go on. Next one.
Oh, yeah.
So that's the fragment and that's the CT. I don't have the whole set of the 3D CT.
All right.
So I know your opinion, but any comments for this one?
That's fine.
That's the pattern of fracture. You can anticipate that this lateral wall is gone. We have kind of a good posterior medial. Can you go? Next one. Next one. And this is the patient at the fracture table. So what to do now? That's a good alignment. The neck angle, it's okay. But there was not a good reduction on the lateral wall. I was trying to push.
Put a cerclage wire, you will win.
So go ahead. I put the cerclage wire on this case. Keep going. And this was trying to do percutaneous, and then I used the hook. I like to use the two hooks. It's a very just half centimeter incision percutaneous. That was the problem. It was not reduced. Again, next one. And then I did a cerclage wire. But my cerclage wire is not to fix anything. It's just to get the tube together. Go ahead. And fix the fracture. In this case, with the long one. Can you just go on? So it's a different concept. I'm not saying, I think a few cases or specific cases, as you showed, the cerclage might be a good way to go. I'm not sure about the plates. Several papers have shown catastrophe with the femoral neck and the plate, and I think that would be the same. The plate as a calcar replacement is not strong enough. And in my opinion, there is nothing that can hold the calcar together if it's not open everything, put screws and plates and everything. But I really believe that the plate, the nail, a well-done plate nail with a good purchase of the femoral head, it's an element. There's one question that it's going to generate a lot of discussion. The cuts through you showed is almost exclusively complication of the blade. It's rare, it's really rare to have a penetration of a cut through with the screw.
Yes.
And together, today, with the augmentation, a cement augmentation for the femoral head, I think that problem we could be solved just with the augmentation of the femoral head. That's the 2 or 3% failures that we have with the nail today. The last report showed 3% failure in unstable trochanteric treated by nail and 8% with the DHS. So with the femoral head, if you have the augmentation here, it's going to be a huge improvement on fixation of these kind of fractures. I don't know. We need to see the result, the studies that come out.
Yeah, I totally agree with you, Paolo. I'm also shying away from helical blade plate to more single screw device. So helical, I totally agree. Helical blade tends to walk away, especially with osteoporotic comminuted fractures. I don't know the reason why.
All right. We'll go ahead with Dr. Tanna sir's case. Sir?
Yeah, this is an 83-year-old female with a comminuted IT. Replacement with the reconstruction. This is what I felt, 83-year-old. I didn't want to try out anything. And obviously this was, as I said, it was a very high-flying, very rich patient, close friend of mine's wife. X-ray, please. Now, this was the X-ray. There is a next, please. This was a traction X-ray. As you can see, the bone is completely in between. There is a gap in between. So I felt this is not necessarily fixable. And even if it is fixable, I will not be able to give 100% result to her. So I proceeded to give a replacement. To me, I think replacement at elderly age group is a far better option than a repair itself. And I've been slowly turning more and more to the elderly people or with too many disabilities. If they are there, then I choose a replacement. And at the moment now, I have never regretted because as I said, I am modified by 2 ways. Next, please. So here was the X-ray. Next, please. So I did this. Now, the main thing which was done was, you can see the LT which was fractured. So I reconstructed the LT with that cerclage wire. So now once you have reconstructed the LT, now it almost becomes like a replacement in a transcervical fracture. And then I have always felt that the way if you do only a trochanteric wire into this replacement, then the trochanteric wire flies out and they always get a lurch and they always get an abductor weakness and everything. So I changed over to this hook plate, which keeps the whole wire, the whole trochanter completely hooked out to it. And if at all needed, I add it up with the cerclage wire also. So this is what was done to us. This is a non-cemented because as you can see, sorry, can you go back one? Can you go back one, Sunil?
Yeah.
And you can see here, this is even at 83, the bone is very good. So I don't do a cemented one here. It is an uncemented prosthesis with the bipolar. Next, please. Now here is the neck, which is here is the, I'm showing you the original gap of an LP, and here is the LP which I dissected it out and put back the LP there. Exactly, it is fitting in. So now their version problems and all those issues have been completely eliminated, making a replacement as a very simple, easy situation. Next, please. And here it is. I have really fixed it up. This is a non-cemented prosthesis. As you know, I have kept it a little proud because of the loss of bone, because you have to ultimately get the length adequately, which you have to have it. Otherwise, the dislocation rate is very high. Next, please. And here it is the G. LT is reduced. Cerclage wire is there. The GT is reduced. The GT is very well fixed up. And then the prosthesis is in order now. And now I have put in the thing, as you can see, I have put in 2 screws from the hook plate distally. Next, please. This is the lateral view of the hook plate, which is there. Cerclage wire along with the screws which are there. Next, please. LT may not heal, but this is the one which gives you the best chance for a perfect replacement. Next, please. This is another patient, identical situation, and I added up along with the hook plate, the cerclage wire, and it was a cemented prosthesis because I felt the bone was not too strong. Next, please. And this is so beautifully walking. 9 months, she started walking almost immediately and so perfectly walking. Next, please. Next, please. Can you go the next, please? Sunil, the next.
नहीं हो गया.
नहीं. Can you just go back? This video, can you click it?
Yeah, video would play it.
Now the next. Perfectly walking. Now it is already 5 years. I know her very socially. 5 years, she is perfectly all right, going out, doing everything.
Okay.
So I feel there is a role of a replacement in those sort of irreparable or difficult repairable IT fractures, which more and more in elderly people, I tend to do it rather than doing the repair. Thank you, friends.
Thank you. So we'll just go through the points what we are discussing. One is why nail fails because of the assessment failure, medial and lateral wall integrity, the gravity with shaft sag with the posterior osteoporosis, the comminution, then the reduction when the no bone to bone compression, large displaced posterior medial and lateral wall, rotational instability with newer implants, focus on this. Then tips to improve the outcome, avoiding complications, assessment with the suitable, whether it is suitable to use a nail, identification of the time, then stable or unstable, involvement of the neck, osteoporosity, use proper and newer implants, reduction, never nail a mal-reduced fracture, bone-to-bone contact, and stability. And with this, we finish it off. We'll just go for question answers.
Stop share. Stop sharing, Sunil.
Stop sharing. Stop.
तिथे जा खाली and stop share screen option press कर.
Green button.
There it is.
Ani, Ashok, can you ask the questions? Whatever has been.
Yes, sir. I got few questions.
Yeah.
And the first question is Dr. Polo showed all cases with helical blade. Is there a role of two screws in usual PFN?
Paulo, you want to take this?
We had a very not bad, but we had kind of large complications with the two screws, like the PFN implants with the Z effect. The idea of two screws were to get rotational stability. That's why the blade came out. The blade, in comparison, has a very good rotational control of the proximal fragment. So we are not using double element nowadays. We are always using single element, either the screw or the blade. More osteoporotic, the blade, it's better because it's a wider area of fixation. But even in such bad cases, it's not enough. So we came out with the augmentation to improve the fixation of the head through the very osteoporotic bones, but we need more studies to prove that this is correct. One tip for if you're going to use the blade, one tip is very, very important. Never ream all the way down. Only the lateral cortex. If you want to use the blade needs to impact the bone. So you open the lateral cortex and you hammer the blade down to squeeze the bone. If you ream in osteoporotic patients, it's a high chance to go to the cut through. So the technique is not to ream, or in very young patients, if you want to use the blade.
Right. The next one is, can you please elaborate the sequence of surgical steps in trochanteric split with lateral wall fracture?
That was the entire symposium.
Maybe the summary of it.
Sunil, you want to take this?
Take it over. You take also.
Another is, what is the standard method for percutaneous wiring?
So you go on the YouTube, punch in surcharge wiring, unstable trochanter, you'll see the YouTube video by me. That's the way I do it. That's the safest way. The only tip which we have learned over a period of time and looking at complications which a lot of people, faculty, trained surgeons have reported is possible damage to vascular structure anteriorly and possible damage to sciatic nerve posteriorly. Always try to stay very close to the bone. When you are passing the surcharge wire passer, you should always feel that grit all the way down anterior to medially. Posteriorly, you will have a fascia which almost always gets detached in an unstable trochanter blowout fracture. If it is not, you have to release that posterior fascia which gets attached to the posterior medial side, which has been very well described by our friend Didi from Ganga Hospital. Once you release that, you should be able to pass the surcharge wire passer flush to the bone circumferentially, and then you come out. That will make it safe. It's a technically demanding surgery. You have to learn it very precisely. Try to do it on a cadaver so that you develop expertise in it. And if you follow the rule of the game, you should be okay to do it.
So Neil, can I add up something?
Yes. Sure.
See, this newer surcharge wire devices which have come, they have come into two sizes. So yeah, unless you have a small size and a big size. If you use a big size, which is not needed, you need a smaller size. It will take a bigger chunk of the soft tissues onto the medial side.
Yes.
And in the international literature, 7 cases have been reported of damage to the vascular. Yeah. And as you know, I have myself have reported one of them. Yeah. And so this is vascular injury is one of the very, very known complication, though not as often as we want it to be. So that's the reason I think you have to be careful, and exactly as you said, unless you are flush to the bone all the time and you are feeling the bone all the time, you cannot pass the wire.
Yes, sir.
Absolutely.
Next is quite interesting. 360-degree wall reconstruction is recommended, lateral wall, posterior medial wall, while reconstruction during PFN. How is it practically possible?
So, can I take this, Sunil?
Yeah.
So the CT scan will demonstrate you which is the major combination which needs to be addressed. Topmost priority is lateral wall. Second topmost priority is anteromedial wall. And the third is posterior comminution. If you use intramedullary device and a lateral plate or cerclage, that will take care of your lateral wall. If there is a purely anterior comminution, the anteromedial plating that I suggested with a good intramedullary device will take care of your intact lateral if it is there. If it is not there, then you do lateral intramedullary device and anteromedial plating. Your posterior can be mostly forgotten, but your cerclage wire loop, which I always do, will engulf all your anterior, posterior, and lateral in one single shot. So mostly if you do it in a proper way, very methodically, mostly you should be able to do it from lateral side and engulf all the 360 degrees with that technique. Sunil, over to you.
In addition to that, if there is a coronal split, I put one small lag screw, 3.5 millimeter lag screw, so that it can hold till the union. Because that one, even if you don't do it, it is going to split more once the abductor starts functioning. So what additional we can put it. So all fragments, as much as possible, you can fix it. That's the only intention to show this.
Another quick word, stay biological. Do not denude muscles from the bony fragments. As long as you preserve the biology and create an intact abductor sleeve, osteomuscular sleeve should be intact. That will give good vascularity. All these comminuted fragments, they will throw a lot of bone and it will heal as one intact unit.
Right. Next is, how do we check stability of fracture fixation after nailing?
Olo?
We can't do that. There's no way intraoperatively we can test it. We can do a few things to improve, like when we finish, we can compress the fracture, try to decrease the gap between the femoral, the head element and the lateral wall. That's all system allow you to do this. But the main thing to check stability is reduction. If you get a nice reduction, if you get a good position of the head element, you can rely that you did a good job. One, on the post-op, if the patient start to walk and had pain more than usually you see on the post-op, then something needs to be checked. But at my knowledge, intra-op, there is no tip to check stability, not just what you did, good or bad.
Ashok, may I answer?
Yeah, sure.
Yes.
What you do after you are finishing the surgery, you do a modified pump handle test. Pump handle test, for normally you do a flexion of the hip. So in that case, you don't flex the hip, slightly flex the hip and keep your C-arm live and see if there is a translation of the fracture fragment as well as the nail. Then and then you can also add to the augmentation by doing testing this. So it is possible, and I have done it in number of times, and I augmented my fixation. So you just do a pump handle test, give a much more stress and see live C-arm picture, and you will find definitely instability at the fracture side after fixation on table.
Tanna sir, can I ask you, are you there? No, yeah. Okay. Next
Yeah,
question.
I'm there. Tell me.
I'm asking you, have you had any occasion that intraoperatively you felt uncomfortable with the fixation after a struggle for 2 hours or 3 hours or whatever time, and you on table took a decision of converting that into a hemiarthroplasty?
Many times, many times.
So what
As a
happened?
matter of fact, as I said,
Hmm.
I feel I'm a little fussy. If I feel like I'm not been able to give you 100% result, then I do not hesitate to just change over the whole thing, take out the patient from the traction table and change over to a replacement.
So what is that scenario? So instability, the implant is not holding. What happens? What is that cutoff?
Yeah, something on the table. I find that the bones are too porotic, and the hardware is not holding, and the reduction is not coming, and there is too much of a combination of the head and the trochanter is completely messed up. Because if the trochanter is completely messed up, then I feel that the proximal part of the nail is not holding at all, and it is only on these one or two screws, in which osteoporotic bone is not enough. So in that situation, I compromise and I really take up the patient for a request.
Same sitting.
Every elderly patient, communicated IT fracture, I have a replacement ready.
Paulo, has that happened with you anytime?
Sorry?
Paulo?
Yeah.
Has that happened with you anytime? That on table you felt uncomfortable with the quality of fixation after 3 hours of struggle, and you changed over, took down everything and converted into a hemiarthroplasty, which is a much more predictable outcome?
Thanks for the difficult question, but fortunately not. Of course, I had many times unhappy with the fixation that I had or with the reduction. But in all the cases, all I had to do is change my technique, improve the fixation with some of the plates or more cerclage, or add some augmentation. But I never intraoperatively changed for arthroplasty. I think that for the femoral neck fracture is a very good solution, but for the trochanteric, because of the abductor loss, I feel very scared to do that. And then in my practice, it happens once or twice, but was decided before the operation. So I try to improve the fixation and reduction, but I never changed to arthroplasty in the middle of the operation.
Okay.
Shall we stop here?
No,
Yeah, I think we can stop here right now.
All right.
Okay. All right. So thank you very much, panelists. Thanks, Sunil, for giving us a hand and so ably moderating everything. Thanks, Paulo. Really appreciate you joining 3:30 in the morning. Hats off to you. We really appreciate that. And
Thank you.
I mean every word of it, Paulo.
It was my great pleasure. Just want to introduce, there was a friend of mine, Cristiano, that was with us since the beginning. So it's a great pleasure. This unit, Brazil, India, it's something that
we will keep grabbing you for more. We will keep grabbing you for more. Thank you, Tanna sir. Thank you, Baba. Thank you, Chetan, for joining us. Thank you, Gadegone sir. Did I miss out on someone?
Kimmat Nitin, your secretary is sitting there.
Thank you very much, Ashok. Really appreciate it. Thanks, Paulo. Thanks, everyone. Sunil, thank you. Bye-bye.
Thank you. Bye-bye.
Sunil, Sushrat, thank you so much.
Bye-bye. बंद के लगा 5 मिनट बोलो की करा